the very kind words. I'm going to forgo my slides in the interest of time. So Steve called himself a regulator. Well, Steve's a regulator. We, the hospitals, are the regulated. What Steve has talked about earlier, is really a description of a real revolution of healthcare in Maryland. As he appropriately said, we're leading the way. Now, there are some good things and bad things about that. The good thing is, it means that we're practicing medicine the way I thought medicine would be when I entered it in medical school over 2 decades ago. You know, we're looking at the patient in that holistic fashion and trying to take care of them across the board, not only while they're in the hospital, but after they leave and before they get there. What's difficult about it, it is a change in the way we've done medicine forever. And for us in hospitals, it's been a challenge to get there and do that. But we've made the transition, and we are doing what is best for the citizens of Maryland and for the citizens of Prince George's County. So one of the most important things that we do, that Steve has talked about, is the ability of taking care of that patient before they get to the hospital, most importantly. But if they arrive there, our goal is to get them out of the hospital as soon as possible. Let me get back from, population health is defined many ways. But most importantly, it's defined as a care of patients in a quality fashion, in a cost-efficient manner. So when our patients enter our hospital, our goal is to get them out as soon as possible, but not only taking care of just that illness that put them there, but taking care of all the other things that were related to it. When they are going to leave our hospital, before they leave, if they don't have a primary care provider they're attached to, we're going to make sure they have an appointment in our clinic before they leave. So we're not we're not giving them a card and saying, well, call me when you get home, and I'll call this number here for an appointment. If they have a provider, then we say, well, call your provider. But if they are not attached to a provider, when they leave our ED, when they leave our floors, we're making sure that they have an appointment in our clinic before they leave our hospital. Because we don't want them, again, to get home and Jesus, where's that piece of paper? Where's that, what's the number of that facility? We want them to have that number, have that appointment when they leave. Within 24 to 48 hours after they leave, we're setting up something called the care link. And that means that they will get a phone call from one of our nurses to ask them, have you picked up your medication, or have you made that appointment with your provider if they're outside the network? We want to make sure that that patient is making connection with the providers outside the network so that they, again, can get the follow-up appointment, their incisions can be checked, their blood sugars can be checked, all so that they won't get back, again, will be less likely to come back to our hospital. The ambulatory care sites have increased in our system by 50% just over the past year. We need to have places for these patients to go. We knew we need to increase our ambulatory care sites, so we've done that. We've developed a partnership with Pam Creekmore and the health department, in part to respond to our need of getting patients to facilities that are appropriate that are appropriate after they leave our hospital. We have also tried to increase the number of things that we have in our hospital before they leave. As many of you know, we had a heart program that was a little on the downside for the past few years. And in July, we brought in Dr. Jamie Brown, who's been from the University of Maryland, who is now leading our cause, and we have almost tripled the number of hearts that we've done this year alone compared to what we've done in previous years. In part because we know that part of the medical problems that we here in Prince George's County face is heart disease. We are working to do the same thing with diabetes as well as hypertension. The clinics that we're developing not only are just for general primary care, but as we look at the readmissions that come to our hospital, they include the things that Steve talked about: diabetes, hypertension, there's heart failure, asthma. So we're opening a new primary care clinic on the Prince Richard site by the end of March, hopefully. In that clinic will be pulmonary care clinic to address asthma, heart failure clinics to address heart failure, as well as hypertension. We're also partnering with other groups who help take care of these patients. We are working with the Mayor Group, for example, to try to take care of a designated group of patients, again, that are frequent visitors at their facilities. The goal being to address the issues that brought them to our clinic, to our hospital, but also to make sure that the other things that are part of their maintenance care takes place. So, for example, if they come to our clinic because they're having problems with diabetes, we're also checking to see have they had their flu shot while they're there. We're trying to make sure that we take advantage of the opportunity to visit to our ambulatory care sites or to our hospital to make sure, again, that we cover the things that are necessary for overall better care. Steve mentioned the need for primary care physicians. For the past 30 years, I've been in the internal medicine program at the Prince Richard Hospital Center. This past year, July, we started a family medicine residency program. It has been our first full residents in the program in July, as I said, and 3 of them were from Maryland. This is done to hopefully address the primary care needs of our community. Steve mentioned the nursing homes and the readmission rates of nursing homes. One of the things that we've just started, a pilot simply started about 3 months ago, is for our patients who are sent to our nursing facilities, we developed something called telehealth. That is, when that patient arrives within 48 hours of that patient arriving at that nursing facility, we do a consultation with the patient and the facility. The question we're asking is, how was that experience? Did we give you enough information to make a decision about the appropriate nursing home? Did we give you enough? Were you informed of when you were transferring? Was the overall experience okay? We're asking the same questions of that facility. Again, to get at having that transfer experience be a good one. We then follow with those patients for every week to 2 weeks, depending upon the disease process, for a total of 30 days. The readmission criteria in Maryland is 30 days. So we want to make sure that we are addressing the issues that put that patient to our hospital, not only while they're there, but beyond there. An example, earlier this week on our telehealth conference call with our patients, he said that his knee was swollen, and he was going to get an MRI. We got the results of the MRI yesterday. We then called the nursing home and says, can we help you find an orthopedic surgeon even for that patient? Because we don't want that patient, again, to develop some swelling in that knee while there and not be able to take care of it. So these are just a number of things that we're doing in order to, the last thing I want to talk to you about is patient experience. We developed what we call a patient experience committee. So a bunch of our patients who have been at our facility that we meet with on a monthly basis to have them help us do better improve their patient experience. During your stay, what was it like for you, and what could we do differently? What can we do going forward? So this waiver, this population health initiative is a challenging one for us. I think we've stepped up the plate to meet that challenge. At the end of the day, I will have more gray hair, but at the end of the day, what overall will happen will be our patients, our citizens of Maryland will have better care.